We are here with Adam Cifu, a general internist and professor of medicine at the University of Chicago. He is a clinical educator, a podcast host, and the author of over 100 peer-reviewed articles, as well as 2 books, Ending Medical Reversal and Symptom to Diagnosis, an evidence-based guide. Welcome to the External Medicine Podcast.
Thanks so much for having me, guys. Really appreciate it.
So before we get started, do you have any financial disclosures?
I really don't. As you said, I have 2 books out there. I get royalties from those, which are pretty much a pittance. So I guess if I start pitching those books, you'll know where that's coming from, but otherwise nothing to disclose.
Great.
So let's start off with a little bit of background about you. For people who are not very familiar with your work and what you do, how do you describe your intellectual interests?
Sure. So I'm a general internist. I really see myself primarily as a clinician. I work in an academic medical center. I'm at University of Chicago. And so, to win my bread, I've got to do some other things. So besides my clinical work, I've spent a lot of time over the years in medical education. And then my, academic pursuits, as they are really thinking about evidence-based medicine, where medical knowledge comes from, and especially, I think, given who I am and how I practice, what we've done wrong, when we've adopted practices and then have to give them up, why that's happened. I find that incredibly interesting. And I think over the last, maybe 15 years, that's kind of been a common thread through a lot of the work I've done.
So you collaborate with Vinay Prasad a lot. How did you 2 end up meeting and start working together?
Sure. So Vinay was a Pritzker medical student, actually, and we met during his 3rd year. I, for a long time, was the clerkship director for the internal medicine clerkship, but really hit it off during his 4th year. I've taught for about 20, 25 years now, a course called Critical Appraisal of the Landmark Literature in the 4th year, which has always been the highlight of my teaching. It's a small class, generally, 25 people, so a real kind of seminar class, where we go through not all the different study types. We cover about 9 different study types. My goal is to try to bring students critical appraisal skills from wherever they are to a higher level, while at the same time sort of saying, listen, you guys have been through the didactic part of your education. You guys have learned some, had some clinical experience. And so this is the time to transition to the reading like you're going to do for the rest of your career. And let's spend some time together just thinking about how you do that, how you look at where medical knowledge comes from, right? How you decide if you're going to incorporate that into your practice. And for anybody who's had anything to do with Vinay, you can imagine him in a class. We spent a lot of time arguing in the class. And then I have to give him, a ton of credit for the work we've done since. Because I think about a couple of years into his residency, he called me up and he said, hey, some of the things we talked about in the class, I'd love to sort of work a little bit further. Can we have lunch? And we sat down for lunch in Hyde Park. We sort of came up with a couple of topics that we were really interested in. I think some of the first things were about diagnosis of pulmonary embolism, use of IVC filters, using coronary stents, PCI for stable coronary disease. And my memory is that, he drove back to Northwestern. I walked back to my office. And by the time I got back to my office, there was an email from him with, 3 students he'd already recruited to work on these projects. And we were sort of off and running with sort of looking at this question and figuring out how to argue it over first multiple papers, but then actually a book where we could sort of extend our thoughts and arguments out further.
So on that note of medical education and your work with Vinay Prasad, the Ending Medical Reversal book, you 2 argue that we currently train students to be reductionists rather than empiricists. What do you mean by this statement?
Yeah, and this is, it's interesting. I think we all know this, right? our views of things change over the course of our life. And as we get older and start publishing things, going back and seeing things, sometimes you're like, oh my God, I said that. Do I still believe that? This is one thing that I actually still really believe. Medical education, basically going back to, Abraham Flexner, right, around 1908, 1911, has been preclinical education where you're going to learn the small parts of medicine, the basic sciences, from everything from cell biology through pathophysiology to pharmacology. And then later you learn clinical medicine. And I think what that does is it teaches students the stories about how therapies should work, and not just therapies, but diagnostics, kind of everything. And because those things come first, they kind of take a primary importance. And so when students meet patients, they're very much thinking about diagnostics and therapeutics very much in the way they learned, say, clinical pathophysiology. So when they see a patient with dyspnea, for instance, they're going back and they're thinking about, how does oxygen get from the air around us to our cells? And they're thinking about, what sort of abnormalities there could make people dyspneic. Or if someone's thinking about treating diabetes, they're thinking about, okay, how do we increase insulin levels? And that stuff is all critically important, and it's critically important for making, for progress in medicine, right? But when it comes right down to it, when we think about treating a patient, right, or diagnosing a patient, all that matters is does something work, right? So I don't really care why the hell an ACE inhibitor works for heart failure as a clinician. All I care is that there's a randomized controlled trial that says an ACE inhibitor decreases mortality. And I'm thrilled that people really know the science. I'm thrilled that there are pharmaceutical companies which can use the science about the angiotensin converting enzyme and the angiotensin receptor to design drugs. But when we talk about, empirical treatment, it is knowing that there's empirical evidence to use these therapies or these diagnostics.
So one of the ideas that you float in the book is, instead of doing pathophysiology first and then clinical reasoning, swapping it and having pathophysiology after clinical reasoning. And I guess I'm sort of curious, is there any evidence that would change how people think about this?
I love it. Saying, this guy talks about wanting to do everything based on evidence, so I'm going to question him on all of these. I totally respect that. There's not, but I guess I would push back. Is there evidence for the way we're doing things now? I guess you can say that, look, we train good doctors, but we do know that we make a lot of errors, right? There are a lot of diagnostic errors. I don't think medical errors are nearly as much of a problem as people pitch. But I think our learning tends to be very inefficient. I think we are set up for diagnostic errors because of the way we train. And I actually think, as an empiricist, I would love to test this. And it would be very easy for, a large medical school or a couple of large medical schools to say, hey, we're up for curriculum reform, okay? And so what we're going to do as part of our curriculum reform is we're going to, randomize students. Let half the students go through a traditional medical curriculum and let the other half of the students go through a curriculum where they spend some time first, learning some of the basics. You need to know some anatomy. You need to learn the language. You need some basic sciences to actually be able to learn in medicine, right? And you certainly need to learn how to read the medical literature, how to understand what you're reading, how to understand when a trial actually really tells you something important. And then the next step in the education can be things that a lot of medical schools do, but as a very small part of their education, is, let students have a clinical experience with a dedicated, clinician educator. And after maybe a morning of seeing patients in the emergency room, in urgent care, in the clinic, sit down for 15 minutes and say, look, what did we do today? What are the therapeutics we used? What are the diagnostics we used? Why don't you spend, I don't know, next couple of hours and look at why we did that. Look at the evidence behind that, okay? And then let's get back together and discuss that. And you'd have a student then learning, why we're doing what we're doing, where there are evidence gaps, why are we still doing that? And you're attaching all of that knowledge to individual patients, which every medical school professor knows is the best way to learn. And I can imagine, God, the rapidity with which students learn in that sort of a setting would be enormous. And then what you would do is you'd say, okay, look, you've had a great, year of experience that way. We do need to fill in blanks because we need you to understand the science behind this stuff, because that's what separates doctors from, and not to disrespect any other field, but from an advanced practice nurse, a physician's assistant who's very much learning, look, when you have this, you do this, or this is the differential diagnosis. We expect our physicians to have a little bit more of a breadth of knowledge. And so a lot of those courses, like pharmacology, like clinical pathophysiology, those could come after some clinical experience. And then in my grand vision, which no medical school will base a curriculum on during my lifetime, then maybe you finish up medical school with saying, most of our students are going to become specialists. Let's let them really dive into that. And our surgeons could do, advanced anatomy at that point. Our internists could do, some sort of advanced decision making. Our radiologists could do, research in the latest imaging techniques and understand better the software that they're using to manipulate images. And I think that we would turn out doctors who had a much more sort of useful knowledge after that.
So you're saying that we would swap clinical reasoning with pathophysiology. So you start with these clinical experiences, and then you're also talking about an end section of medical education where you would start specializing within medical school instead of waiting for residency. Do you still? Yeah, go ahead.
Yeah, I think it's what the real importance to me is that what students learn first is clinical care, and clinical care with the recognition of what's important is the evidence that you're working on that clinical care, right? You understand, why am I doing what I'm doing? Whether it be a diagnostic, a therapeutic, providing prognostic information, all the things that we as physicians need to do. I totally recognize that you need some vocabulary before doing that. So there needs to be a little bit of training before, I can start sitting with a student in clinic and saying, this person's on these 4 antihypertensives. This is why I started these 4 antihypertensives in this order. Okay. And then I think actually a student who then does a pharmacology class, having had that clinical experience, is going to learn much more from that pharmacology class compared to a student who goes into pharmacology never having actually treated a patient and not knowing that you need to make a decision between multiple antihypertensives before. And then I think we waste a lot of time. I've often said, as it is designed now, the 4th year of medical school is this like outrageously expensive vacation, right? People spend half the time doing nothing or doing things that are worthless for the rest of their career. Well, let's maximize their time. Most students already know what they're going to do. They're dedicated to what they're going to do. And imagine they're like the budding orthopedic surgeon who, can take a month to dissect a knee, right? Like, that experience is going to be so valuable, and there's no way to do that in our present medical education system.
Yeah, I also think that we waste a lot of time in those first 2 years as well. Like, to the extent that those first 2 years are just preparing for USMLE Step 1, that could be done before medical school to a large extent. I mean, a lot of people who are international medical graduates they study for USMLE Step 1 and then go into clinical stuff afterwards.
Well, I'll cheat a little bit, and I'll have you guys help me with an article that I'm working on right now. You can completely imagine changing everything that goes on before medical school, right? I mean, I think you guys are closer to it than me, but come on, the things we require of college students before they apply to medical school is ridiculous. You know, the year of physics, come on, that's like crazy, okay? But there are some things which we don't require, which are very important, right? You know, like biochemistry, for instance. There are certainly things like human anatomy that you can make an argument, or I would make the argument, is, you know, an obvious part of a liberal arts education, right? That boy, any student who's sort of interested in their own health and the human body would be interested in taking that class. And then given that so many students these days are basically homeschooling themselves during the first 2 years of medical school, why do medical schools even need to be responsible for that, right? Have a medical school entrance examination, which is actually asking students to have the knowledge that they would need to enter the Adam Cifu curriculum, this made-up curriculum, right? So if we could select students that have done, performed at a certain level on this exam and shown in an interview that they could be in clinic with me on day one, and be a partner in sort of learning and maybe even helping me in clinic, boy, that would be amazing. And you could imagine, the sort of empiric clinical training for a year, followed by a little bit of the sort of catch-up sciences for a year, followed by specialization for a year. And then, maybe we get people out of medical school faster with a little less debt. Actually, probably the medical schools would all raise their price by 25% to make sure that they don't lose any money, but we'll leave that to the business people.
Yeah, the other problem that I had with I'm on board with this idea. I like this idea.
I've won you over.
Yeah, except for the raising of prices, that I'm not so okay with. I was thinking we could just chop off a year and a half and do it in 2.5 years, and then I'd save, and not have. Yeah. The other thing that bothered me about my biology education and cell biology in medical school was the way things are taught. It's presented as finished knowledge. Like, here is how things are, as opposed to here is how we figured out all of these different enzymes and how they work. Here are the competing hypotheses. Here's what things the scientists behind the scenes were looking at. I mean, you can't go into great detail about all of this, but, have you seen that meme where it's like the real Krebs cycle, and it's this circular thing, and it's like, learn the Krebs cycle, forget the Krebs cycle, learn the Krebs cycle, forget the Krebs cycles. I just feel like learning how we learn what we know tends to be so much more valuable. And I remember it. With my brother, went to a pre-med post-bac program, and we had this great teacher who taught us how Banting figured out about insulin and the chopping up of pancreas and injecting it into, I think it was dogs. Like, that stuff really sticks with me. And I think there should be more of that.
Yeah. I think one of the big problems is, we don't invest enough in the preclinical educators, right? It's often people, basic scientists who are sort of, called upon to teach a couple of classes. Sometimes there's a kind of clinician educator who's overseeing it. And what you lose is the two other approaches, which I think is the approach you talk about, that, boy, make the science exciting, right? Tell us about the process of discovering this and what led to the, development of the questions and then the way those questions were answered. Or, and I think this is done a little bit more, but still not enough, is, for everything, whether it be the Krebs cycle, whether it be, intestinal absorption of carbohydrates, you can come up with spectacular cases and disease entities of like, look, we're going to start with celiac sprue and the starvation winter, and get from there. Start with a person and get all the way down to the cell biology. And in that, and I think students would be more open to that if they've already had some clinical experience.
One thing I think we were talking about before we started recording was this critical appraisal of the landmark literature seminar that you run. I'm curious, what are the top trials that you tried to bring out in this course?
Yeah. It's fun because, as I said, I think I started this class, I think in 1999 was the first time I taught it. And what I did before that class is I chose a bunch of really, really landmark trials. So if I go back, and I actually pulled up on my computer just to sort of remind me, what were the randomized controlled trials that I felt were critical at that time? And it was things like the 4S trial, right? One of the very first statin trials, the DCCT, the diabetes control and complications trial that sort of showed us that the euglycemia hypothesis was critical. The CAS trial, which you guys mentioned, cardiac arrhythmia suppression trial, which showed us that whatever type 1C antiarrhythmics were actually dangerous when you use them in the post-MI period. And then what's happened over the years is that the first half of the course is always, you students choose things from my syllabus. And, there's an RCT day, there's a case control day, a cohort day, and, on and on. And then in the second half of the course, it's okay. You guys, you're on your own. Choose a paper, whatever kind of paper it is. It may not be ideal to talk about, errors that are made in RCT, but it's, as long as it's one of the 10 trial types that we talk about, we're happy to entertain it. And it's also been great for me because not only has it kept the article set very much updated, but it's also broadened it really far from my, sort of intern-oriented, list of articles. And so, we end up with a ton of pediatrics articles, a ton of orthopedic articles, quite a few, mostly gynecologic articles. There's very few obstetrics trials that come out. And what's neat is that then you end up with these arguments where, a budding orthopedist says, I want to talk about this trial because 3 attendings handed this to me during my sub-I. And they're like, I'm talking about this because this is like, a foundational text in my field. And then, the dermatologist sitting next to her will be like, the hell are you talking about? This is trash for reasons X, Y, and Z. And people already have divided into, team ortho versus team derm. And it's great to see those discussions. And it makes people truly, critically appraise the medical literature.
So I guess moving on from Cifu Medical College to medical conservatism, a few years ago, you co-authored an essay on being a medical conservative with Vinay Prasad, John Mandrola, who was a previous guest on the podcast, and Andrew Foy. Could you define medical conservatism and what you mean by that term?
Sure. So medical conservatism is really a way of looking at medical practice, which I think puts the utmost importance on knowledge that a treatment is actually beneficial to a patient, and beneficial to a patient at the level of improving clinical endpoints that are important to the patient. It favors that over, and maybe this is sort of the link to medical reversal and what we've already talked about, but it favors that over sort of the newest things with the best story behind them. It says, I'm going to use drugs that are well proven and maybe less expensive than things that are shiny and new. It thinks a lot about the absolute benefits of those treatments. So it's having discussions with patients, talking to them about, look, this is honestly how likely you are to benefit from that from this intervention. So patients can really make educated decisions about what they want to do. And it's funny. I have to say, I think John and Andrew were the primary movers of this article. Called on Vinay and I, based on our work, to read it, think about it, make some edits, and I didn't find it controversial at all. I was like, well, this is good medical care, and maybe the things that people are going to object to the most is that we're calling it medical conservative people. Medical conservatism, and when people hear, conservative or liberal, they're immediately triggered and fall into their camps. But it's interesting that there is a pushback to these ideas because people, equate this with medical nihilism, and I am about as far from a medical nihilist as is imaginable. They think this is sort of anti-intellectual, that it's, we're not going to adopt new therapies, we're going to be against progress in medicine. And I'd say all of those ideas are kind of crazy. I think it does mean that within a clinical practice, you're probably not going to be the early adopter of every therapy. And therefore, maybe every now and then you're going to be a little bit behind in adopting a therapy, but more often than not, you're going to save patients using therapies which are found to not work. And really, in 21st century medicine, when we have a beneficial development, it is generally a very small step forward. I don't think we're forever beyond, statins or protease inhibitors. Hell, we've just been through perfecting mRNA vaccines, which have completely changed the course of a pandemic, right? Those things happen. But when those things happen, it is clear. And all you have to do is look at those initial vaccine trials, right? Even the most medical conservative would read that first article in the New England Journal and see the separation of those vaccine curves and know, like, this is something I need to give day one. And so I think for the most part, medical conservatives may move a little bit slower where it's appropriate to move a little bit slower.
Yeah, one question I had while reading that article was, are you suggesting that every doctor should be a medical conservative, or were you suggesting that on average, doctors, we should shift that like midpoint to be more medically conservative?
That's a hard question to answer. I recognize that fundamentalism in all its forms is a bad thing, right? So me saying you should all take the, Adam Cifu, John Mandrola philosophy of practice, makes me feel like some sort of crazed, medical evangelical. But I would say that I think moving all of medicine a little bit more in that direction makes sense. And that even the people who tend to be, the greatest optimists, the maximalists, the early adopters, that if we can put a little medical conservative on that person's shoulder to whisper in their ear and say, listen, I know the drug rep who just talked to you told you why this medication is, going to be God's gift to medicine in the 21st century. But pause for a minute and think about why that may not be the case, and think about what sort of evidence you would need to be absolutely sure that that's true. Recognize that you don't have that yet, and maybe move a little bit more slowly.
Don't know what's going on with my mic. It's going on, it's going off, it's going on again. Okay, we're good. This topic of medical conservatism relates to your previous work about medical reversals. So what is a medical reversal and why are they important?
Sure. So when I talk about medical reversal, I always like to start with medical replacement. And replacement is kind of how we want medicine to advance. It's saying we have a therapy, we've developed a new therapy, we've had a clinical trial that shows that that new therapy is better than what we have, and we replace the old with the new. And that's how we want things to progress. And when I say therapy, I don't just mean medications. I mean diagnostic tests. I mean understanding of prognosis. I mean surgical interventions. Anything that a doctor does. What reversal is when we have a therapy, let's say a medical practice, and something new comes up, and we adopt that thinking that it's better. But we have not waited for the most robust evidence. And what happens then is that we adopt it, we put it out into the world, hundreds of thousands of patients get that new therapy, and only then do we have robust data come up which shows us that that new therapy is no better than what we'd had before, usually no better but more expensive, or sometimes even worse than what we've had before. And we need to reverse ourselves and go back to that initial therapy. This is also completely different from coming up with a new treatment, studying it, find that it doesn't work, and going back to the drawing board, because that's just science, right? That's what happens. And the difference between that and reversal is that we haven't deployed it, into the clinical world before.
Can you walk us through some examples of prominent medical reversals?
Sure. Maybe what I'll do is, as Vinay Prasad and I worked on this, we each started with sort of a critical reversal in our career. And I think that's what stimulated both of us to commit time to this, and to show that I'm much older than, Vinay, certainly, than you guys as well. My critical reversal was estrogen replacement therapy. Whereas I trained in medical school in residency, estrogen replacement therapy was the thing we did. When a woman went through menopause, we, as sort of primary prevention, said, your estrogen levels have fallen. It's good if we put you back on estrogen replacement therapy. And it's good because it's very beneficial for your bones. It's a little bit negative for your breasts, but it's very beneficial to your heart. And so on balance, it's beneficial. And for my first couple of years of practice, I gave that spiel, to dozens, if not hundreds of women. And then, in the late 90s, early 2000s, we began to have randomized trials that showed us that at best, estrogen was a wash, had no benefit, and at worst maybe did some harm. And we had to go back and say, estrogen replacement therapy probably has a role for treating bad postmenopausal symptoms for 6 months to 2 years, but it's certainly not something we should do routinely as prophylaxis for the entire population. For Vinay, I think it was PCI, percutaneous coronary intervention for people with stable angina, which was, look, here's a person who has angina and they have a 70% coronary stenosis of one of their 3 coronary arteries. We should go in there and fix it, open it up. They're going to do better. And then over first the Courage trial, which was 2009, and then the Orbita trial in, I think, 2016 maybe, we learned that really was not the case, that maximal medical therapy is as good for those patients, both in terms of future heart attack, even future cardiac death, and even in terms of symptoms was just as good as intervention and a whole lot cheaper, a whole lot safer. And at the time that the Courage trial came out in 2009, some unbelievable amount of Medicare dollars, I think 80% of the Medicare dollars being spent on PCI was being spent on this group of patients rather than being spent on the group of patients who benefited definitively from PCI, which are people who just had a heart attack or had unstable angina.
Has there been another like small reversal back for estrogen replacement therapy such that now they stopped giving it for everyone and now they're like, well, for symptoms and in certain people it actually can be pretty beneficial?
Right. Well, this is kind of the cool thing, about studying this is that most of the things that that are adopted too early are not absolute garbage, because scientists are smart, doctors are well-meaning, and we're trying to do the right thing. And I would not have known this or said this 10 years ago, and it certainly doesn't even show up in our book. But very often what happens is that the things we call medical reversal is that we decided that we should do vertebroplasty on everybody who has a spinal compression fracture, okay? And then we find out that that is absolutely wrong, okay? And there's a reversal. And then what happens over the years is that the technology gets better and we get a little bit smarter about what patients this therapy is indicated for, and that this therapy may end up being very appropriate for a very small swath of patients, okay? And why reversal is important and the understanding of reversal is important is that, figure that out before you deploy it for everybody, okay? I am absolutely sure that in the dozens or hundreds of women who I gave estrogen replacement therapy to, I injured some women. I took care of some women who absolutely were injured by their estrogen replacement therapy, right? They had complications of that therapy, but it's very unlikely that they had just, cryptogenically, right, out of the blue. And it would be wonderful to have, instead of me, Adam Cifu, giving estrogen replacement therapy to 100 people, 99 who didn't need it, is to figure out first who that one person who would actually benefit from it is and just use it in that person.
It's interesting, this tendency to view things as very black and white. It reminds me a little bit of breastfeeding, like 100 years ago or 80 years ago. Like no one really breastfed. It was all formula for a while and it was seen as unhealthy to breastfeed. And then the pendulum swung the other way. And even now, although I think it's starting to change a bit, it was like, you must breastfeed. Like to do anything but that is harmful. And now it's sort of like, well, like certain people, it's actually harmful to have them breastfeed. And so over time, nuance develops.
Right. It's interesting the way you say that because, clearly the guiding ethical principle to medicine today, right, is in shared decision making, right? We went through thousands of years of paternalism. We went through a couple of decades of like patient autonomy. And now it's that, listen, we share decisions. We're supposed to be the expert in the medicine. The patient's supposed to be the expert in their values, let's say. There's a little bit of overlap, where I can articulate the patient's values maybe a little bit better because I've been through these conversations so much. Patients certainly come to us with a lot of knowledge these days, right, which they didn't have 50 years ago. And so the decisions that we make are nuanced. And in a way, I think there's nuance lost in the way we read the literature, and that like this works or this doesn't work. And it's funny because the nuance has always been there, right? When you think about, absolute risk reductions, right? There are very few therapies we have that have 100% absolute risk reduction, right? They're all 50%, 30%, 20% absolute risk reductions, which means that, probably a majority of patients are not going to be helped by the therapy we're using. And so these should never be black and white, actually.
You've done some work trying to actually quantify how frequently these medical reversals occur. What do we know about how common they are, and how do we actually know that? What was the methodology to determine how common these are?
I think what we know is that trying to figure out how common they are is a fool's errand. Okay. I'll tell you what we've done, and I think it has value, obviously, but I'm not sure it's an answerable question. What we've done generally is to look into the literature and sort of throw away studies that looked at basic science questions. We're sort of not interested in those. Look at clinical questions and look at clinical questions that are asking questions about things that doctors are already using. And then of that, so, okay, we're taking a standard practice or a widely used practice that's now undergoing a robust clinical trial. And we're seeing, what percentage of those practices kind of get debunked, right? That's reversal. What group of them tend to be upheld, right? And that's, I guess, kind of reaffirmation, we're doing the right thing. And then there's always a subset that, you still can't figure it out, right? And you're lost. And I think, and we've had numbers when we look at individual journals or multiple journals, which range from anywhere from about 15% of what we test to all the way as high as about 45% of what we test turn out not to be effective. And so I think what I leave our work knowing is that, there's a lot of stuff we all do which we don't have great data behind. I think every doctor would admit to that. You can't practice medicine without doing some things which don't have RCTs behind them. We only test a subset of those things. And when we test those things, it turns out that at least a sizable majority turn out to not work. And we shouldn't be doing those things. And we should abandon those things, which is a whole nother literature that it's very different to abandon something which doctors have already become attached to for all sorts of both psychological and economic reasons. Probably.
Bed rest, I think, was that's been mostly, if not entirely, abandoned.
Well, bed rest is such an interesting thing, and I'm always careful when I start talking about things that I know nothing about. I'm not an obstetrician. I am B, not a woman. I am C, a father of 2 children, but my wife was never on bed rest. So what the hell do I know? But at the time that we were recommending bed rest was unheard of in Australia, right? So when there are 2 countries treating something completely differently, you know that there's a huge gap in the medical literature there, right? And there's a question that needs to be answered. And with something like that, one of those continents, let's say, either Oceania or North America, are actually doing harm to either a woman or a baby, Either more women are miscarrying in Australia, or are having DVTs and going absolutely insane in North America. And Jesus Christ, answer that question.
Yeah, it's interesting. Our father actually had a hernia operation a while back, a couple of years back. And I remember looking into how many different ways you can just repair an inguinal hernia. You can do it with mesh. You can do an open approach. You can do the more different options there are, the more skepticism I have that any one of them, everything's going to have problems.
Right. And the question to add on that, because I often talk about this with incontinence surgery, right? If there are 10 approaches, it makes you realize that either none of them are better than another one, or maybe none of them work at all, right? At least hernias, we know that people generally don't have a hernia after they come out of surgery. It's just a question of which of those creates the most, off-target effects, let's say. Sorry, I interrupted you.
So the example of looking at different countries and evaluating what practices they recommend or don't recommend is kind of an interesting idea, because physicians, through our training, we become very accustomed to the ways that we were taught, independent of what the literature may or may not say. I was curious, have you heard of prediction markets or the use of prediction markets to try to find out what is true about the world?
I have not. I mean, what I do know, and I'll let you expound on it, which is I sort of where I thought you were going, which if we look at practice patterns just within, a country, right, and seeing how much things vary from region to region, um, A, makes you skeptical of what's being done in all regions, but sort of opens up an opportunity to study outcomes. But tell me about what you're talking about.
What I was talking about with prediction markets is, there's work by Philip Tetlock at University of Pennsylvania, where in order to try to predict things that are not a long time in the future, but say, how many missiles is North Korea going to shoot off in 5 months? And rather than having a bunch of talking heads say there are going to be a lot or a little, actually having people quantify what they think is the number by December 5th, how many are going to be shot out. And there are actually people that are really good at predicting quantifiable events in the future, which makes me wonder if you get like a group of, say, experts in a room on, general internal medicine or the topic of bed rest in particular circumstances, and wouldn't be a prediction in that case, but sort of a poll on them to see, okay, what is the general will of obstetricians think in this particular circumstance? Try to get the bottom of what the RCTs are actually saying from a community-wide perspective.
Yeah. I hate to disrespect talking heads while the three of us are having a conversation, right? But I think the problem with medicine, it maybe goes back to where our conversation started, is that we are so biased in our thinking based on our training, our patient care experience, that I don't really trust anybody. And it's the reason that I'm so kind of dedicated to using the medical literature where I can, because, I know some people who, colleague X who knows more about hypertension and diabetes than anybody I know, I don't trust that guy about new drugs, because he's heard, he's so caught up in the science and has heard all about the early trials and the animal studies that, like, he's going to be wrong. And I'd almost rather have a medical student who can really read articles and has no preconceived notion tell me what she thinks.
Yeah, I think that the innovation behind prediction markets, which I think the concept comes from Robin Hanson, is that it's very easy for someone to opine on an opinion page or on Twitter and be wrong and not suffer any consequences from that. Right. Whereas if you're putting your money on a particular outcome, you have more skin in the game, and therefore,
Right. And can bow out, right? I mean, to say, I can't answer that question. I don't know, because I am a big believer in the wisdom of the crowd. And if you only get people who are really confident in what they're saying, to give a number, I can see that being helpful. I disagree with your contention that people opine on Twitter, because that's just crazy. Nobody says anything.
Yeah, I think the phrase is like, a bet is a tax on bullshit.
Right. That I'll buy.
Yeah. So just to kind of jump a little bit deeper into these sorts of very common situations where we don't have good clinical trial data, or the study that needs to be done would take 30 years, or it's just there are too many variations. Like, should we do 3 days of antibiotics, 3.5 days, 3.75 days? No one's going to do all those studies. So how should physicians decide things and recommend things and believe things based on all of that uncertainty?
Yeah. So I think it's critical to understand the evidence that there is, because on just about everything that we do, we're fortunate in the 21st century to have some evidence that we can draw on. It is important, I have to say, to also, use experts. I'm a generalist. I do, on questions, call colleagues who I think know more about this than I do. I do treat their opinions, if it's not just a fact, a study I don't know. I treat their opinions with a little bit of a grain of salt because I think about who they are. I think about their practice patterns. And then I understand, I try to get as much useful information as I can to discuss with the patient. And these honestly are the longest, most difficult appointments for me. If someone comes in with a blood pressure of, 160 over 100, and I'm putting them on a medication, that's easy. You got to start a medication. I think you should do this. This is going to be the side effect. If that side effect is going to make you crazy, we can go with this. It's the harder decisions where I need to tell the person, look, you're probably going to be fine, but we can reduce your risk a little bit. And this is the likelihood you're going to benefit from this therapy. This is what taking the therapy means, or getting this XRT or whatever means. And you need to decide. And that person's going to have a ton of questions. They're probably going to say, what should I do? And you're going to say, well, wait, let me hold on this because it's really your question. You're going to be the one who's going to have to take the medications. Are there questions that I can answer? And if I can answer them here, I will. If I need to call you back tomorrow after I've looked some stuff up, I will, to make sure that that person's comfortable with the decision they make. Because so often we can't be that sort of expert that they want us to be.
All right. And on that note, we can move to a couple of rapid fire questions before we run out of time. So
this is where you try to get me to screw up and say something that I don't want to say.
Yeah, and then we're going to cut that clip out, and that's going to be all we use as advertisement. All right. So what are one or two important papers that physicians should be more familiar with?
Oh, that's a great question. So I'm going to say, and I'm going to say this sort of off the bat just because I still have that list from Critical Appraisal of the Medical Literature up in front of me. I think an article which goes back a little bit, about 10 years to 2019, it's a New England Journal article, and a lot of people know this article. It's the transfusion strategies for acute upper gastrointestinal bleeding. And I love that trial because it is a really elegant, fairly simple trial, which looks at something that we had assumed and done for a long time, which is, we should transfuse people to a safe range, and randomizes them to that or a threshold for transfusion that would have scared the hell out of me as an intern, and what's amazing is that it makes no difference. And maybe actually doing what we had always done is wrong. And that's one of those great trials that you can do, and you can sort of learn something from the trial, but also think deeply about why we accept kind of gospel. This is how we do it. And if you read that trial and understand that what's being tested and what sort of fails in that article is what had just been assumed to be a normal practice pattern for, 50 years with nobody really questioned it, it's amazing. And it makes you think about all the things that you're probably doing, right now without questioning that are wrong. The other trial that I find that I go back to over and over and over again, and this, is going back into the absolute deepest, darkest archives, is a case-controlled trial, which must be from, the 1980s. I'm going to get it right up in front of me. And it is from March 12th, 1981, also from the New England Journal of Medicine, coffee and cancer of the pancreas. And it's this amazing case control study where they compare people who are coffee drinkers with people who are not coffee drinkers, and show quite definitively that coffee is associated with, let's jump to say, causes cancer of the pancreas. And the trial is completely wrong. And the trial is completely wrong because of how they selected their controls. And their control patients, for reasons of their underlying medical conditions, were just much more likely to be coffee drinkers than the people with cancer of the pancreas, who were mostly fine, healthy, drinking coffee, until their pancreatic cancer got them. And that just always reminds me that, boy, observational data is dangerous. And over the years, we've had some really elegant studies which look at questions which have been addressed by observational studies and randomized controlled trials. And it shows us that observational trials are pretty good at showing, what we think is truth. They probably succeed about 75% of the time, but there's no way to predict the 25% of time that they fail. And so when you're using observational data, you have to just remember that, maybe there's a 1 in 4 chance that what I'm doing here is absolutely wrong.
Next question. If you had unlimited funds for a single RCT, what would you fund? It could be trying to find out if coffee really does cause cancer of the pancreas, but I suspect it won't be.
I would definitely not fund a coffee study, a vitamin D study, anything like that. I think I would be very interested in, because of what I do, in actually the value of the doctor-patient relationship. We spend a good deal of money on trying to have people have regular, stable, ongoing relationships with physicians. That is something that I believe in. I believe that works. It's what I commit my career to. But if a stable physician relationship does not provide patient benefits, we're wasting a lot of money. If a stable patient-physician relationship is beneficial, we are cursing a large swath of our nation to poor health care because we're making it increasingly difficult for patients to have that sort of a relationship. And so I would love to know if sort of a robust primary care relationship is actually beneficial, probably both at the patient level and maybe at the sort of healthcare expenditure level. I'd like to know, do patients do better, and do we spend more or less money in either direction?
What important medical truth do very few of your colleagues agree with you on?
I think where I've gotten into, most of my colleagues know me well, and they know when to roll their eyes when I get into my, well, do we actually know that work? I think probably where I've gotten into most trouble lately is in 2022, right, how we think about COVID. And we almost got through this whole podcast without talking about COVID. But it is a field where, as time goes on, we have real certainty on a few things, and I think greater and greater uncertainty on more and more things. And I know your question was a truth, and I don't know the truth about this, but I think I have more and more colleagues who are willing to just jump on what's ever recommended without good data behind them, and that's making me progressively more uncomfortable with our treatment recommendations.
Next question is, what would you have become if you didn't become a doctor?
Guys, these are hard. So I'll tell you what my other dream was that I was on the way to doing. I was very interested in becoming an art conservationist. I was a chemistry major in college with a secondary concentration in art history. I grew up with art-loving Italian parents with lots of friends in Italy, and I have had times in museums where I felt like I was having some sort of religious experience and felt like maybe I missed my calling. I love medicine intensely and can't imagine anything else which would give me the satisfaction and feeling that my time is well spent. But the idea of spending a year, caring for a painting rather than 20 years caring for a patient still stimulates me a bit.
All right. Well, thank you, Adam, for joining us on the External Medicine Podcast. For anyone who is listening, where can someone look you up if they want to learn more about what you're doing?
So first of all, guys, thank you so much for having me. Your questions were amazing, and I actually wrote down a couple of things as we were talking to think about in the future, which is always the hallmark of a wonderful conversation. I think the couple of places to find me these days, certainly I spend a little bit too much time on Twitter, so I am there as just at Adam Cifu. Pretty much all of my work is at a website, adamcifu.net. Just look that up and you can find everything I've written, appearances, podcasts, things like that. And I think, not to undermine you guys, but the last couple of years, I did a clinical education podcast called S2D. I'm very excited that in the next month, given one of my new roles at the Bucksbaum Institute for Clinical Excellence, we're going to be releasing a clinical excellence podcast, which I think is going to be really exciting. It's going to be very short, 20-minute or so podcast, which won't at all therefore cut into your audience, where we ask really knowledgeable, experienced people, not only physicians, but actually patients as well, just 3 questions to get a sense about how people think about various parts of healthcare. And I'll be relentlessly, shamelessly promoting the Clinical Excellence Podcast when it comes out.
That sounds great. We look forward to listening to the podcast when it comes out.
Thank you once again for joining us. We really appreciate it.
Thank you too.